to be here. This is I like to think of one of a number of talks on important or major medical problems. And I don't know how many of you have had the opportunity to hear some of the other talks, but if you could please put into the chat any suggestions that you have for topics, because I can choose topics. I want to make sure the topics are something that is appropriate and germane to your experience and needs. So asthma is what we're talking about today, a major medical problem worldwide. Next slide. And what we want to do is, what are your goals? What are you trying to do with an asthmatic patient? One, you want to control their symptoms. You don't want them to wheezy and short of breath. And you want to reduce the risk that their asthma is going to get worse. But you also want to be cognizant of the fact that when we give the medications we have for asthma, there are side effects. So it's a balancing. You want to improve the quality of life of your asthmatic, and that asthmatic should be able to work, play, do sports, anything that they want to do without worrying about their breathing. I mean, that's the ideal, and you try and achieve it as much as you can. Next slide, please. Okay, so how do we manage a patient with asthma? And there are 4 components: education, controlling what causes the patient's asthma to get worse, carrying on or looking at their symptoms in their lungs, how they're doing, and of course the medications we're going to use. So let's move on to number 1, which is patient education, which is the next slide, please. And really for asthma, it is like almost for every other condition we've talked about. It's really important that we educate our patients, because if you have a patient who understands what their illness is, and I don't care whether that illness is asthma, which we're talking about today, or diabetes or hypertension, if you have a motivated patient, a patient who wants to help participate and take care of their own medical problems and work with you as their provider, there is very good evidence that you're getting a much more effective result. Your asthmatic patient, your diabetic patient, which is not who we're talking about today, will do better because you have taught them, you've educated them what they can do. You're going to do your part, but there's certain things they have to do. Next slide, please. So one of the important and very important parts of asthma treatment is finding out and then avoiding what are the quote triggers. So some people, for example, can be triggered if they come in contact with certain plants or flowers or pollen. Some people by cigarette smoke is mentioned here. There are other triggers that people have that cause them to start wheezing and have a problem. So what you have to do is help with asking your patient, have you noticed any time when you tend to get worse with your asthma? If they say, yes, well, if I go in a room where somebody's smoking, I tend to start wheezing. Okay, well, then you ask me, what can you do? Sure, you can say, I don't go in the room, but perhaps you can ask people not to smoke there. Perhaps if you're going in, you can look for ways of ventilating the room better. These triggers, of course, occur not only in the patient's home, but in the workplace. So there could be various chemicals at work that are in the air that are triggering somebody's asthma. You've got to let somebody try and find it out. Now, I don't know about regulations in Kenya. In the United States, companies are responsible to try and minimize the products that are liberated into the air where people are working, which are dangerous or harmful. And that would include something that triggers somebody's asthma. Now, what you can do also, there are other triggers that for people's asthma that you can't do anything about. For example, physical exertion. If somebody is going to play soccer and they find that after running a quarter of the way down the field, they start having trouble wheezing, you can't say to them, don't play soccer, that's very good. It's an enjoyment, plus it's good for their physical health. So you're going to have to control that trigger, not avoid it. Also, sometimes a trigger is a cold, a flu-like illness. Emotional triggers for certain people. People have to learn from you how to manage, adjust, change the possible reasons why their asthma is getting worse. Next, please. Now, what you can do also is you want to monitor how your patient's lungs are doing. Now, there's two ways of doing this. One is you can do a pulmonary function study. I don't know how readily that's available. Even here in the United States, yes, I can send a patient for pulmonary function studies. That's really difficult, inconvenient. They've got to be off work. They've got to go to an office. But you can do something very simple. You can say, look at an activity you do every day. You walk from A to B. You carry a package. You're doing something. How is that today compared to when it was a month ago? Can you walk further up the hill before you have to stop because you're wheezing? If you're at work and you're lifting boxes or packages or items from place A to place B, do you have to stop sooner now than you did last month? Or are you better since I've treated you? I mean, it works both ways. So what you can do, you can use this as a way of knowing how the patient is doing, but a way of indicating when you should see the patient next. Because if the patient comes in to you and said, I used to be able to go halfway down the soccer field before I got short of breath from my wheezing, and now I can only go a quarter of the way down. You know that you're going to make some changes in how you help that patient. But additionally, you want to be able to say, okay, when am I going to see you next? Well, you don't want to wait too long. You want to see if what you're doing is working. Next slide, please. Next, after you've taken the history, you've discussed it with your patient, you say, okay, I know what triggers your asthma is triggered by cigarette smoke, is triggered by pollens, is triggered by physical activity. What am I going to do to help you? I can't tell you not walking. I'm not going to tell you, stop doing things. But let's look at the pharmacological treatment. What medicines can I give you? And you base your choice of medication on the patient's age, on how their lung function is. And it doesn't have to be a formal lung function study. It can be an informal thing. When you walk from your house to work, or when you go up the soccer field, that's a really good measure of lung function. You can compare it. How far do you go? And what are your risk factors? Risk factors is the patient morbidly obese? That can make a difference. Is the patient a smoker? Definitely make a difference. And also, what medicines are practical for that patient? Can they use the medicine? If you're going to give an inhaler, are they comfortable using it? Do they know how to use it? How easy is it to get that medicine? Because when you talk about, for example, an inhaler, my experience in Canada and the United States is most people do not use it properly. They think they are, but unless you demonstrate and show them, and in my case, I would have the patient do an inhalation in front of me to show me what they're doing. Initially, I would say, show me how you're using your inhaler. And then if they were not using it properly, I say, okay, let me show you how really to use it. And that is something I think which is really important. Let's move on. Okay, what are the other conditions that we worry about? Well, if somebody has a sinusitis or rhinitis, if they have COPD, the obesity I mentioned before, sleep apnea, What happens if they have a mechanical obstruction in their vocal cord? Also, stress, emotional well-being makes a major difference, not only for asthma, but almost for every condition. If you're feeling well, is that you're a lot more likely to do, to use your medication properly than if you're depressed. I noticed a little note. Is any problem with my microphone? And I don't know if I can change it. I hope people are able to hear me okay. Next slide, please. Okay, let's say you have a patient who comes into you and they're having problems. We're not talking now about, we're talking about a patient who already has symptoms of asthma, they're asthmatic, and they come in because, gee, doc, I'm having trouble breathing right now. You can hear them wheezing. First thing to do is you give them an inhalation. And you albuterol or one of those medicines. Now, when a patient inhales, you ask them to take their inhaler, hold it in their hand, shake it, make sure that it's there, you can sense that there's something in it. You ask them to breathe out, and then as they're breathing in, they purse their lips around the inhaler and they activate the inhaler by pushing on it. And they keep breathing in until they've got the full breath, but then you ask them to hold that breath. Now, it may be difficult in the middle of exacerbation to hold it too long. I usually suggest 10 seconds to count to the number slowly, the number 10 in your head. Then to slowly let that out. Why you do it that way? That allows the medicine to go and be diffused into the lungs to become a bronchodilator. And what I often suggest to patients is you don't do a second inhalation immediately, but you wait 4 or 5 minutes and do it a second time. And this way, it really potentiates that medicine. At the same time, depending on how your assessment of how severe this attack is, you can start them on a short course of oral steroids. And really, there's no better guideline than your assessment and your knowledge of the patient. If you think that this is an acute attack because the patient walked into a room with a lot of smoke and they started to have problems, they came to see you quickly and you gave them an inhalation, you waited 5 minutes, you gave them another, you wait a little bit and they say, doc, I'm a lot better now. And I'm getting back to how I feel I was. Okay, you don't need to start steroids. But if at the end of that second inhalation, they say, I'm a little bit better, but I'm still having problems, and you listen to their lungs and they're still wheezing, they're not good air entry, definitely you're going to tell them to keep using the albuterol every 4 to 5 hours, but also you'll start them on steroids. Next slide, please. Now, what happens if you get this new patient? Somebody comes in and they say, doctor, I'm coughing a lot and I feel short of breath, and I just don't know why it is. You take your history, you do your physical, you say you're hearing them wheezing. This is the patient who's not been treated before. You start them on either an inhaler of just plain albuterol or levobuterol, short acting. You teach them how to use it, or you can start them on a combination of a steroid and a bronchodilator inhaler. Both are acceptable, and the choice depends on a number of factors. Your assessment of how severe this patient's asthma is when it presents to you. And that will go, there's a number of ways of gauging that. How far did you have to walk before you noticed trouble breathing? Oh, you walked the length of the football field, or soccer field rather. Okay, that's pretty good. It's not as severe as you can only get a third of the way there and you had to stop and wait for a few moments before you can carry on. In that case, you may use the combination inhaler rather than the first one. If you have a patient whose triggering symptoms are activity, you can predict when they are going to start having trouble breathing. The soccer player who says, suddenly, once I start in the game, after a few minutes, I'm stopping, I'm coughing, I'm having trouble breathing. What do? You have them take their medication prior to the activity. Hockey in Canada and the United States is, of course, a major game. And I had a number of, because soccer was not as prevalent here years ago, I had many patients who were hockey players who had asthma, who before the game, 10 or 15 minutes before the game started, they would take their inhalations and then be able to play a period of time. If would take a break, may take a few more inhalations, and could play the rest of the game. So to review this, in a patient, you're starting off either just simple albuterol, short-acting agent, or combination, depending on your assessment of how severe that patient is when they present. If you have a patient who says, I only have asthma before certain activities, before I go into a lecture at a hall where people are smoking or an event, those people you can treat before the event that they know they're going to do and just use it then. So the rest of the day, when they're not in that environment or they're not doing that activity, they don't need to worry about taking their medicine. Next slide, please. Now, what you have to do is once you started somebody on the medicine, you just don't let them go and say, okay, here's your medicine. It's the same as if you started somebody who's a diabetic on their medication. If you started somebody who has hypertension on their medication, what you do is therapy is stepwise. You start on the medicine, you see how they're doing. You bring them back to you and you say, okay, are you better? Yes, I can get halfway down the soccer field now, but I can't get to the end if I'm the one who's in the lead. You adjust the medicine. If you have a patient who comes in and says, medicine is working, but I get this heart racing from the medicine and I get a tremor, you've got to step it down. Each visit, you have to check with your patient how they're doing, because asthma is not once you have it, it's always the same. It's variable. It changes over time, and you have to adjust it according to your patient's needs. And the only way you know how to adjust it is the history from your patient. Because when that patient is sitting in front of you, they may not be wheezing because they're in a quiet environment. But as soon as they do something, they may start to wheeze. They may be wheezing, but, and you're going to document that, but is it the same as they were wheezing before? And you use a 2 to 4 week assessment. And there are peak flow. I don't know if you folks have easily peak flow meters, but you can use a peak flow meter as a simple, quick office tool to see how they're doing. When they, with a forced expiration, how much can they move that meter? Next slide, please. Now, if you have a poorly controlled asthmatic, you've been giving them their therapy and you step it up, you step it down, then you may, and they're not doing well, and you have to start looking at other options. And there are other options, such as oral steroids on a daily or alternative day basis. When you're using a steroid, of course, we're all aware of the risks of chronic steroids, diabetes, ulcer formation, hypertension, etc. There's a list of them. If you can get alternative day steroids, your risks are cut way down. So ideally, you could put a patient on that. And I don't know which of the long-acting muscarinic antagonists you have available or the leukotriene modifiers. I'm sorry, I wasn't able to find what is available in Kenya. I only know the US, but you can consider adding these agents. And all these slides are available till afterwards. So if this is something I would have to look up what is available. I happen to be talking to you from Canada now. The agents that are available here are slightly different than the agents available in the United States. I'm sure there are differences in Kenya. I would have to look it up if I was treating somebody in Canada versus US for what agents they have. Next slide. Also, once your patient is doing well, you'd like to reduce the amount of medicine. We tend not to do that for some other conditions. If you have a hypertensive patient whose blood pressure is at goal, where you want it, 120/80 or whatever, the goal for that patient, you tend not to say, let's cut back medicine. You tend to say, keep on with that medicine, you're doing great, and we're going to protect you. On the other hand, if you're inhaling steroids, which you needed, or you're on oral steroids, but this is talking mainly about inhaling, you want to try and get it down if you can. So a patient comes to you and says, doc, I've been doing great. I've been doing everything I want to. And you say, well, how many puffs are you taking? Well, I'm taking 2 puffs twice a day. Cut it down by 1 puff. And since maybe most of their activities during the morning, you cut it down in the evening. Slowly try and step down if you can, but have that patient come back to you then and say, okay, I decreased you by 1 puff. Has that made a difference? If they say no, and it's been a period of time, you say, okay, we can maybe decrease it more. If they say, yes, I'm not as good as I was, you've got to step it back up. And these are all the adjustments you're making and documenting along the way. Next, please. Okay, one item that we have to remember is that not everybody who's wheezing has asthma. Wheezing means there's an obstruction, there's a narrowing to our airway somewhere along the way. So when a patient comes to present to us and their main finding is wheezing, they will have the symptoms of shortness of breath, but you listen to wheezing, you can't automatically assume it's because of asthma. So what the next part is going to be is what are the other causes that we have to keep at the back of our mind when a patient presents with wheezing? Because I think we've sort of reviewed the treatment of asthma, starting off with making your history, your physical, your monitoring, you're starting off slowly, building up your acute treatment. Let's move now to the next slide. Okay, there's one way of looking at causes of wheezing. One of the ways of doing it is look at where we think that the wheezing or the narrowing comes from. What we call extrathoracic, nose, mouth, larynx, and the outside the trachea. The next step down is a little further, and then further down into the lungs. So this is using an anatomical way of looking at causes of wheezing. There are other ways. This happens to be, I think, an easy way to remember. Next slide, please. Okay. Anaphylaxis. If you eat a food that you're allergic to, given a medicine you're allergic to, you've got an insect sting, you've sent the patient for an x-ray that involves a dye that they're given, and they can start wheezing because there's swelling of the airway, the vocal cord swells, you can get a problem because of the anaphylaxis. The vocal cord, you can also get vocal cord paralysis from a number of reasons. You can get laryngeal stenosis if a patient has been irradiated. If you've had a patient who was intubated, and that caused trauma, or it was intubated for a long period of time, you can get stenosis. As a personal story, Before I became a doctor, the very first surgery I saw was of a thoracic surgeon who was removing parts of a patient's trachea because they had been intubated for too long. They couldn't help that. And they had narrowing there and they had wheezing. And they went in and literally took out part and replaced it with a Teflon segment. And very large tonsils occasionally can cause wheezing. Unlikely, but it happens. Next slide, please. Now, a goiter can cause compression and wheezing. When I was in Ethiopia, I saw a number of patients where you didn't have to examine for the goiter. You could see it across the room. It was that large. This could be putting pressure on the airway. It causes wheezing. The treatment is to treat the goiter and the wheezing goes away. Also, if you have sinusitis, it's the most common. This is a very small series, only 34 patients, but they went to a clinic and they had difficult to control asthma, and the most common cause of that was rhinosinusitis. Something you have to think about. Is it not only your patient is wheezing, but are they stuffed up? Are they nasal drainage? Something to put in the back of your mind when you're taking your history and when you're examining the patient. Next slide, please. Okay, let's move down. We talked about the tracheostenosis. Also, there are tumors which can cause the central airway. This is moving further down in the airway from up above. And this is just an obstruction of either the intrathoracic or the main stem bronchi. These are physical causes often, and this can be after intubation, some scarring, reflux with aspiration, because with reflux, you will get the acid coming up and it may spill into the airway. And once it does, you've got acid where it does not belong. You've got the swelling, the scarring, the edema, the wheezing. Next slide, please. Okay, mucus plugs can cause wheezing. Cystic fibrosis is one of the causes, as is asthma, but there are other causes. Pneumonia can cause wheezing. It's not primary asthma, but they present with wheezing. Or a mass in the mediastinum. Now, I don't know how often you folks see thyomas, germ cell tumors, lymphoma, and how often you have sarcoidosis, and then the goiter as mentioned before. Interesting enough, herpes simplex 1 can cause a tracheal bronchitis that can cause wheezing. So these are all cases when you're examining a patient, you have to have in the back of your mind, not that you're going to do an extensive investigation for every patient that wheezes for a mediastinal mass, but you've got to realize that that is a possible cause. And look, for somebody who has a lymphoma, they'll probably have other symptoms, fatigue, etc., that you're worried about. The goiter, change in thyroid function and change in how they're doing. Next slide, please. Now, within the airway, there are a number of causes. Infectious bronchiolitis. So an infection in the airway can cause wheezing. You treat it, yes, you may have to, you're going to give them something to open up the airway. You're going to give them a bronchodilator, but you also want to treat the best you can the infection. Now, if it's viral, there's not much you can do. But if it's bacterial, clearly you can treat the pneumonia, bronchitis, which is rarely bacterial, but you can treat that with an antibiotic, and then you don't need to worry about ongoing wheezing. Now, there's something called cardiac asthma, and this can cause wheezing. And as it says here, this is thought to be to the vascular congestion and the edema that narrow the airway. Finally, parasitic infections can cause wheezing. I don't know, that is not something that's not something that's seen frequently in the US. I imagine from my reading that that is something that the providers in Kenya will have much more experience with, because that where you are geographically is much higher incidence of parasitic infection. Next slide. So how can we know where the wheeze is coming from? What can we do clinically? You want to see, when you listen to the patient's chest, is it diffuse wheezing? Is it better through the chest wall or over the neck or the back? Is it very focal, such as only one area of the lungs? And this will give you an idea. If you're wheezing diffusely, front and back, you've got the, it's much more likely to be a diffuse process than if it's just one airway, one part of the person's lungs, the lower segment in the right or the left back lung field. Next slide, please. When do you do a chest x-ray? You should do that in all patients who don't seem to respond to your therapy. So you don't need to rush everybody into a chest x-ray. But if you get a new patient who has refractory wheezing, or actually even a brand new patient who's wheezing significantly, not just a little bit, sure, you can do a chest x-ray, and you tell your radiologist, this is why I'm doing the chest x-ray, and you look for changes. It does not show, however, central airway lesions. And that's the disadvantages of a chest x-ray. So some of the main stem lesions are problems that would not necessarily show up very well in a plain chest x-ray. And the next slide. Okay, let's look at a treatment guideline. Initial steps, if somebody comes in and they've got relatively rapid onset, they say, gee, I was well until a day ago, and now I'm starting to wheeze, I'm having trouble doing things. Ideally, you check their pulse ox. You can do an arterial blood gas if it's feasible. You give them a treatment immediately, ideally with a nebulizer. That is a much more effective treatment for somebody who's acutely ill than using an inhaled device. And if it looks like it has signs of anaphylaxis, epinephrine immediately. Then, if you think that patient is so bad or poorly that they're starting to go into failure, then is when you start giving them oxygen, and you start getting somebody in and you talk about intubation and trying to find out what's going on. That hopefully is a case that not many of us will see, but you've got to realize if a patient is starting to go downhill rapidly, you have to consider, definitely the bronchodilator, definitely starting to give them oxygen, and definitely considering intubation. And I don't know how many facilities have that ability. Most offices in the US do not have that, but obviously many clinics do. Next. That's it. I think we are there. Do we have some questions, please? And thank you very much.
Well, thank you, Dr. Hart. And we already have some questions trickling in. The first one is from Eric, and he would like for you to differentiate between cardiac asthma and bronchial asthma in their presentations and management.
Okay. Management is probably easier. For management, if you're having problems with congestive failure, you're managing the congestive failure, your diuretics, your other agents. If you're worried about asthma, you're using the oral agents. The differential, With the cardiac asthma, you've got other symptoms suggesting congestive heart failure, perhaps edema, basal rouse, in addition to some wheezing for the fluid buildup. You may or may not have changes on your EKG, on your cardiac sounds, if the patient, a gallop rhythm as the patient is going into heart failure. So that is, a lot of it's based on your clinical assessment. There's no hard and fast, but usually if you have a cardiac problem, it's going to be to that point where you're talking about cardiac asthma, where you have compromised pulmonary function. You're going to have also the other signs of your cardiac condition. You're going to CHF.
Very good. Thank you, Dr. Hart. And in the same vein, we have another question asking you to differentiate between viral bronchiolitis and reactive airway disease based on their clinical presentations.
Oh, very good. Okay. If you're to differentiate between viral and regular asthma, like basically what you're asking about, if I understand, your viral illness comes with the other findings of illness. Chills, fever, maybe some sweating, all the signs that you've got an illness. It could be bacterial or viral. You're coming in, I've developed something acutely. The asthma patient is going to come in basically with a breathing problem. They're not going to say, they'll have a cough, most likely, but trouble breathing. But they won't say, I think I've had fevers, chills, sweats. When you ask the history, often somebody else in a viral illness has been ill in the family, at work, one of their friends who says, oh yeah, my friend had a cold or had a virus, I think I've caught it. Versus asthma, everybody I know around me okay, but I'm having trouble now lately walking, I have trouble breathing, I feel short of breath. The symptoms would go with just narrowing the airway, and there's no other infectious cause. And what you have to resist, this goes back to an earlier lecture about the use of antibiotics. 95% of bronchitis in the US, and I probably can use the same, is viral. Viruses do not respond. However, with COVID, as you know, COVID causes major lung problems, and you are going to treat COVID with what we have available and the agents that are out there. So that would be the differentiation, because now these days you always have to think in the back of my mind, if somebody comes in with a viral illness, is it COVID? And that's so we're doing here in the US COVID tests all the time. Personally, my brother just had a cold the other day. He did 2 tests just to be sure it was just a cold and not developing COVID. Next.
Thank you, Dr. Hart. No, we have even more. What is your opinion on the use of subcutaneous adrenaline in the management of acute asthma in the emergency department in the absence of a nebulized agent? And they're also wondering about the use of IV immunophilin in resistant cases that are not responding to nebulization.
I will have to get back to them with that answer, because I've never, fortunately where we are, I've never encountered that. We have, the US has resources, but that has not been, but it's an excellent question, because if you don't have a nebulizer, I'm used to giving epinephrine as a single subcutaneous injection, and that's it. As far as an ongoing treatment, I will definitely, if I can trouble you to send me that question I will have an answer back to that question, and we'll make it for everybody, because that's an excellent question. What do you do if you're resource limited for some of the suggestions that I've given? What are your other options?
Very good. And I'll email you that question, Dr. Hart, and share the responses with all participants. The next question we had was about pediatric acute asthma. What is the management of a child with reactive airway disease?
Okay, same idea, but you have to taper it to the child. Ideally, it's going to take, I don't think a child can start using an inhaler themselves until 8, 9, if you're lucky. I don't, and I did not mention, I should have, a spacer. Instead of having the asthma device in your hand and put it just in your mouth, there's a tube, a spacer that goes from the device to your mouth. And what you do is when you put the device in the tube in your mouth, you squeeze the inhaler, and the medicine goes in the spacer when you breathe in and out through the spacer. So the medicine does not go beyond the spacer, pushing your lips around the spacer. Medicine doesn't go in the air, but goes back and forth in your lungs and makes it easier. That is something that you can use in a slightly older child. In a younger child, what we do here in the States is we use a nebulizer with the child sitting on the parent's lap or the provider's lap. So you go and you put the medicine in the nebulizer, you put the mask over the child's face, you're holding the child on your lap, and you have the child breathe in and out, and you do it much the same way, same indications. If that child starts wheezing, you would do that. You also would have to do that during the day if you're putting your child on a number of inhalations during the day, because a young child who can definitely have asthma, can definitely suffer from it, can't use a spacer. And you prefer not to put a young child on steroids if at all possible. If you need to use a dual agent for the child, you have to. But again, try to avoid steroids if you can in that child, any child.
Wonderful. Dr. Hart, the next question we have is, how do you differentiate between crackles, rales, and wheezing?
Okay. Wheezing is that whistling sound, worse on expiration, or you can have it when you breathe in sometimes too. Rales are described to me as taking, is Saran Wrap a product in Kenya that people use? And I don't know what the equivalent is. It's sort of it's like if you take, in the States, you take Saran Wrap and you move it in your hand, it gives a very specific sound. And I don't know if that is something that people in Kenya, I don't know whether, I will again put that in, I will get a better way of describing rails that other than what I'm used to here, because it's like a bubble, it's almost like a bubbling sound, and they're distinctly different sounds. And crackles, it's or what we might call rhonchi, or a harsher breath sound, that sometimes will clear with cough. So if you've got some mucus in your lungs and you ask the patient to cough, it will often clear up the rhonchi. It will not clear up the wheeze if there's some reason why you have the narrowing, or if you have fluid at the base of your lungs, and actually you have the rales. And rales are, you hear that with a pneumonia, with congestive failure, with some reason why you've got a fluid trap, at the base of your lungs. And also location makes a difference. Very rare that usually the wheezing is more diffuse. The rales, the rhonchi can be throughout the lungs, but clear with cough, and usually at the bases for congestive heart failure.
Very helpful, and I'll add that to the list, Dr. Hart. A few more questions. When nebulizing acute asthma attacks, is there a superiority in nebulizing via oxygen versus room temperature?
If you can check a pulse ox on the patient, good question. If you can check pulse ox and it's normal, you don't need to add oxygen. If that patient's oxygen saturation is in the low 90s or below, yes, you can add oxygen, it'll make it more effective. So and now I don't know, and maybe we can find out how many of the providers have pulse oximeters, a little handheld device. And if not a lot of patients have that, and we may be able to find out a way of providing them through the Addis Clinic to our providers. I think we can probably raise some funds to do that. They are in the States inexpensive, but extremely important because it gives you a very quick clinical guideline as to how your patient is doing. So if you come in, if you have a patient who's wheezing and is at 92, and you give them a nebulizer treatment, and they bump up to 95 and 96, you have an objective finding, besides the fact you're going to listen to their lungs and you say they are better, and they say they feel better. Yes, it's an additional measure that you're succeeding. Or if a patient comes in and you've got that number, you say, yes, I need to add oxygen because I'm at 88 or 89, and that patient is starting to become oxygen deprived.
Very good. The next question we have, and I think we'll have time for 2 or 3 more questions, is can you comment on acute asthma precipitated by upper airway infections like a common cold?
Yeah, for some people, that's a trigger. As I said earlier before, asthma can be triggered by a number of items. It can be you're allergic to pollen. My wife starts sneezing and wheezing if there's some flowers in the house and somebody brings her for, oh, here you are, here's some flowers, very nice. That would trigger it. But colds can do the same thing. That inflammation, that infection would trigger asthma in a number of people. And you can avoid the flowers. You can't, unfortunately, avoid the cold. But you still, in both cases, can trigger. One, it's easy to remove the flowers, and that goes back to looking at what are the triggers for that patient's asthma. If you know it's a certain food, if you know it's a certain activity, you can modify that activity. If you say to somebody, every time you walk up 2 flights of stairs, you find yourself wheezing, walk up, here, we're going to give you an inhaler, and you're going to use that inhaler 4 or 5 minutes before you're going to go up the stairs, and this will make it easier for you. If you notice there's 2 flights of stairs, we're going to have to give up 1 flight and pause for a little bit before you go up the next flight so you can get your lung function returning. We can't do that with the cold, but we can give them the inhaler to make their breathing easier. And if it's a bacterial infection, we can give them antibiotics. As I said before, vast majority are not, but there are some. And the clinical guidelines for bacterial infection do not include the color of the sputum. When I was going to medical school, we were taught if it's white, it's a virus, if it's colored, it's a bacteria. That is not the case, we know now. We cannot look at the color of the sputum that our patients are producing to make that decision. Is this a virus or bacteria? I don't want to harp on something I did before, but I think it's important to keep realizing that because many patients feel that they will get better if they're given an antibiotic, irrespective of what else we do. And we have to, the best of our ability, resist that temptation to say, sure, here is an antibiotic.
Very good. Next question. Is it advisable to use steroid nasal sprays in children having recurrent upper airway congestion?
You like to limit steroids in all children. You can use them, but on a limited basis. I don't think, and I will double check, one more question to put on for me, that there is really good data that shows that these are safe for long-term use. Because depending on the age of the child, if you get a child who's 5 or 6, and you're talking about using that for years or for a long time, you're giving them a steroid at a time when they're developing. So I'll double check and I'll get the data back for folks. But ideally, you use it as infrequently as possible. Also, you do not want to use some of the nasal sprays, neosynephrine, sprays like that in the United States, which have epinephrine in them, because what happens is it shrinks the airway, it shrinks the mucous membranes, but then you get a vicious cycle. They shrink, they enlarge, they use the nasal spray again, it shrinks down, they enlarge, and people can almost become dependent upon that from repetitive use. So sometimes just a matter of Mucinex, which is safe, steam baths, things like that to help with the congestion are a lot safer. And assuming, again, you've got to make the differentiation between a bacterial, if it's a bacterial infection, and viral. Majority of viral, there are occasionally bacterial. Next.
Very helpful. And we'll go into our last question, Dr. Hart. Is there any role of aminophylline and wheezing management in neonates and prematures?
Not that I know of. I will look that up. As an aside, I was going to be a pediatrician initially, and then I decided to become a family doctor. But before I left pediatrics, the hospital I was in suggested I become a neonatologist. I never did. Very, very difficult part of medicine, very precise. I will have to look that up and get back. So I have my homework to do, which I will, and get back to it. Thank you for the excellent questions. Please make some suggestions. I don't know if anybody did already. We have 29 participants here. Please make suggestions for another topic that will be helpful, and it will be done for you.
Wow. Thank you so much, Dr. Hart, as usual, for leading such an impressive and engaging webinar. And to all of our attendees, as Dr. Hart mentioned, we'll send a follow-up email shortly after this call. Please respond to that email with any questions you weren't able to ask, and also with any suggestions for future webinars with Dr. Hart. And I'll mention this one more time. If you're not signed up for our free telemedicine services and you'd like to have access to excellent physicians like Dr. Hart to help you treat your patients, I dropped the link again in the chat. Please fill out that form. We'll reach out to you to use our free telemedicine service so you can help treat your patients alongside exceptional physicians like Dr. Hart. Thank you, everyone, for taking.
Well, thank you for keep doing that for me. It's very kind of you. I'm not just an average physician, but I really, really enjoy, and this is such, I keep telling people how amazing the Addis Clinic is, because it shows what telemedicine can do, really, from one side of the world to the other. And you have phenomenal doctors there in Kenya doing amazing work.
That's exceptional. Well, thank you for your kind words, Dr. Hart. Our work would not be possible without you and the other volunteer physicians inside of our volunteer medical corps. So on behalf of everyone, thank you for your time and thank you for your continued service. And we look forward to our next webinar with you, Dr. Hart.
My pleasure. I look forward to it too. Bye-bye now.
Bye, everyone.